Okay. Yeah. Thank you for listening in on today's episode of Inside an Indian Country, and thank you so much for having the time to listen to us today. Got a very special guest in today, Melissa Goad, who's a seasoned healthcare professional, and really had the opportunity to sit down with her and talk to her about her experiences, more specifically in the healthcare industry, but also even a little deeper than that is revenue cycle optimization. So for those of you listening in, I really hope this is an opportunity for some education and Melissa sharing some of her experiences and how you can possibly take this and apply it to what you have, or at least just from a workflow management process, and really some real good gems in here. So Melissa, thank you for
Thank you.
joining us today.
Thank you for having me. I'm
Yeah,
looking
yeah.
forward to this.
Oh yeah, me too, me too. um why don't you go give our listeners a little insight on who you are and your journey, and especially with tribal healthcare.
Absolutely. Well, thank you. Thank you. I appreciate being on the podcast today. Well, I'm Melissa Goad. I'm a CPA. I've got about 30 years of experience in the healthcare industry. I've been really blessed to work on both the payer and the provider side. So I have this dual heritage that really allows me to see issues from a much richer context than I would be just having one side. I did have the fortune of being able to spend 2 years as the CFO of a 638 tribal healthcare facility on the Navajo Reservation. And when I was with that organization, I was responsible for the health of their revenue cycle. So it was really my experience there that lends a lot to this conversation today.
Yep, yep, yep. Um, some great context for listeners, just so that you know that, hey, this has gone through it, seen it, and really lived it. Um, just as far as the importance of revenue cycle management, what are some key things that you think listeners out there should know?
Mm. I love that question. So for me, I am very passionate about the revenue cycle. I think optimizing the revenue cycle, which sometimes you'll hear referred to as RCM, it's not just about the financial health for an organization. It's really about ensuring continuity of care and honoring that commitment that we've made to the community in a culturally appropriate fashion. When I think about tribal healthcare, it is similar and different from non-tribal healthcare, but I will say it does face some unique challenges. So, with tribal healthcare, you frequently have geographic isolation. You have staffing limitations, like any place has. You have complex billing regulations, and oftentimes you have inadequate technology. So a lot of the same things that any non-tribal organization faces, just in a more amplified fashion, if you want to say. When I turn my mind and start thinking about healthcare in the tribal setting, I really do think the fundamentals of healthcare billing is the same as anywhere else in the organization. Tribal facilities do have an alternative payment structure through Medicare and Medicaid for their beneficiaries, and it's called an all-inclusive rate. The all-inclusive rate methodology, it introduces some complexity to healthcare billing for tribal facilities, but it's really not all that different than some of the global payment structures that have existed for 20, 30 years in the payer space for specific episodes of care.
Hmm. Hmm. No, yeah, and I think that's where um that organization definitely probably had an opportunity to benefit from your experience, right? And so really, if you could take the listeners through kind of your journey as you came from a non-tribal space into a tribal space, and then just some of the things you've seen, and then what prompted you to start thinking about where can we improve this cycle. That'd be great.
Thank you. So, when I joined the organization, I quickly realized that the revenue cycle had a lot of opportunities in our particular environment. So we took a two-prong approach. We first spent about 3 months doing an assessment just to understand what we were dealing with, not leaping forward with a bunch of assumptions, but really understanding the true environment that we lived within. And then we spent about the next year and a half taking that assessment and putting together a remediation plan on what we were going to do to ensure that the facility received payments that was due the organization. We hadn't, that opportunity really broke down into two main areas that I thought I would share with the listeners today. The first area of where we saw a lot of opportunity was around embracing industry best practices. Healthcare billing is pretty much the same anywhere you go with just some nuances here and there. But it was really getting back to industry best practices as an organization as our fundamental operating principle. And then the second was around looking at re-implementing our revenue cycle portions of our EHR so that it was more complementary to the clinical workflows that were happening in our particular facility.
Hmm. Hmm. So when you came in, was there any specific, process that you saw that um, you you noticed immediately? For example, maybe not following up on claims, or just kind of curious, or even if you can maybe dive into like what are some of the best practices to consider.
Yeah. So I approach revenue cycle optimization from the viewpoint that there are 5,000 hospitals in the United States, nearly 4,500 to 5,000, depending upon who's counting them. In our facility, what we were doing was not high acuity or high volume. There were other hospitals out there that have thousands of beds that do everything under the sun. They've learned a lot of things through their years. And when I think about best practices in the revenue cycle, I really came to the realization that yes, our AIR introduces a complexity, but the fundamentals are the exact same as any other hospital in the United States. So we really did try to go through standardizing our practices so that they were complementary to what the industry had experimented with and found was best practices. When we really anchored in those proven industry standards, a couple of things rose to the surface for us. The first area that rose to the surface was charge capture and coding. Uh, when a clinical event never reaches the revenue cycle, you're never going to have an opportunity for reimbursement. Just if it doesn't get there, it's never going to be reimbursed. It's never going to go out as a claim. So when we did our efforts around optimizing the revenue cycle, we really looked and did a deep scan of our charge capture processes and our coding accuracy so that we could identify some revenue leakage because there were opportunities that we never docked a claim for. So we were no one's ever going to pay us if you don't tell them that they owe us. So when we looked at those, when we saw medical events were not passing from the medical record over to the billing system, sometimes this was due to either interfaces not transmitting the data. We did have a particular challenge in that space and spent a lot of time and effort addressing that. We also saw that the manner in which the clinicians were capturing the clinical event and the medical record sometimes wasn't necessarily complementary or easy for the billing teams and coding teams to be able to turn those into a claim. So we worked really closely with our clinicians to ensure that the data that was happening in the clinical workflows was passing on to the revenue cycle workflows. So we really focused on leadership buy-in with our clinician leaders so that as we looked at workflows that we made it easy for them to give us the data we needed to be able to bill. We also looked at data transparency, so making certain the data had its integrity as it passed from one system to the next system, making certain that all the data went over, because with a clinical event, you have a lot of fields on your claims forms you have to fill out, and so sometimes you don't have that data. And so then we really tried to make certain that as we were realigning our goals around the revenue cycle, that it was complementary to what the clinicians were doing in their space, and we didn't overwhelm them with changes. Another area where we had some opportunities and started to put in a lot of effort was around denials management. Any healthcare leader out there is going to tell you denials are kind of the bane of their existence. It was no different for us as an organization. Payers love to deny. Then on the payer side, I know we like to do that. That is kind of one of the blessings that I have from having seen that. So when we were looking at denials, we really focused in on a cross-functional team to help us analyze what was happening with the denials. Some of the denials would be due to just procedural denials that they're going to deny for any case. Some of them are going to be missing clinical information or that whole concept that something wasn't put in the record that they needed to prove it. The basic premise in healthcare is if it's not documented, it didn't happen. So we really did think a lot about that. And so as we started going back through and looking at our denials, we found that there were a couple of areas that were really problematic for us. And the first area was that starting point, registration. We had issues with registration. We had numerous eligibility denials because we weren't quite capturing all the information we needed to be able to appropriately identify the payer of record for the particular beneficiary that was presenting. We had to go through in that area a reconfiguration of our systems, which would really have been the eligibility verification system and how we collect that data from the different payers or validate that payer. And we also had to look at what information was passing through those eligibility efforts onto the medical record and then out of the medical record onto the coding and billing systems for revenue. We also found another area, surprisingly, was at the very back end, the absolute opposite, which was cash posting. So we really recognized we needed to get smarter about cash posting. So we weren't capturing all of the data that came in on EOBs. And the reason we weren't is we didn't realize that we needed it. And it goes back to the whole concept of go to best practices, go to the industry standards. There's a reason people do this, and there was just not an awareness that we needed to capture some things. So what was happening for us in the cash posting space was every denial we had was a unique body of work. We worked every single claim. When we started capturing all that information, we were able to go back and consolidate those denials into classes of denials. So instead of fighting a denial on one claim, I could fight a denial on 1,000 claims at the same time. Same amount of effort, more reward to be had for that. So those were the two big areas in that particular space that we looked at straight away. Now, in my opinion, remediating a revenue cycle, it's a layer at a time. You got to start with some of the fundamentals, verification, cash, and then build upon those. We also had some gaps around our technology, around our EHR. Now, any listener to this podcast is going to really know that EHRs can be a pain for everybody. They always overpromise and they always underdeliver. So it was no different for us in our organization. But what we had done with our EHR is we had done customization. And customizations on any system implementation is the real gotcha. That's where you get into a lot of trouble with a system implementation. So we had heavily customized both our clinical workflows and our revenue cycle workflows. And going back to what I said earlier, there's nearly 5,000 hospitals in the United States. There wasn't anything that we were doing that was unique that wasn't being done somewhere else.
Right.
There wasn't any really solid business justification for us to have all of these customizations. Standards of care are the same throughout the United States. It doesn't matter if you're tribal or non-tribal. Standard of care is the same standard of care for anyone in the United States. Revenue cycle activities are pretty much the same. Now, a lot of people will push back and say, oh, we've got the AIR. We've got the AIR. Yes, the AIR is unique, but it's not that unique. If you go back 20, 30 years and look at global reimbursement rates that existed back then for different medical events, it's kind of the same sort of concept to be had. And today, many of the payers have these global rates through some of their commercial contracts with facilities. So the AIR was really not a justification for a customization either. So when we really started looking at these and realizing our customizations was the problem we had with our EHR, we took an effort to try to strip all those customizations out. Now, we didn't get rid of all of them because you have to be pretty slow and methodical in doing that. But we recognized that they weren't driving value for us as an organization, and it was just creating problems is all that they were really doing. So we did put a lot of effort into that. So as we got into that space of customization, you can't rip them all out at once. That's just way too disruptive for an organization. We tried to classify our efforts into, categories and then tackled the categories with the greatest promise first based upon the absolute dollars. If I've got, many thousands of claims, denying for a particular event, I'm gonna focus on that, first as opposed to the one where I've got a few hundred claims denying. We did try to look at things like surgical claims because those tend to be high paying claims for organizations. Those kind of lower volume but high dollars. So we did try to really bring some of that thinking into it. So it was a really slow process of going through that. But it was very important for us to go slowly because we were not only unwinding customizations in our revenue cycle, we were unwinding customizations upstream in the clinical events, what we were asking the clinicians to document or not document, what we were asking them to do around some of the measures and metrics that they would pass over to us related to the patient, some of the vitals and those sorts of things. So we did really try to be aware of the fact that we had limited staff and we didn't want to overwhelm everyone, but we did want to get everything that was due us at the same time. So it was a bit of a balancing between that ability to secure all the reimbursements that we were entitled to without creating so much overwhelming work for both our clinicians and our rev cycle team that we would fail on that. So we took things slowly as we went through and just started unwinding each of those. So as we moved toward standardizing our system, there were a couple of issues that just kept coming up over and over and over for us. The first issue I would say was really around data. Our data was not flowing. In a well-designed EHR, it's almost invisible, the data moving through your system. Ours wasn't. Ours was catching in various areas. We had built interfaces that were one directional. We just sent data to a particular application and we didn't get the data back. Well, there was a reason we sent the data there. There was some data we needed to get back. And so we went through our interfaces. That was kind of the first area that we focused on and looked at each of our interfaces to understand were we transacting the data appropriately. We changed a lot of interfaces from one directional interfaces to bidirectional so that we got the data back that we needed. That was particularly important in the coding. Your encoders are generally not present in your EHR, so you have an offline tool that you use to do that. Well, I got to get that data back from it. So we looked at those different interfaces and addressed those. We also lacked the ability to really see our data in a full schematic. So we didn't really know where things were falling out in the process. We might know that a patient came in and we did some eligibility verification. And then when we got to the point of submitting the claim, we had an eligibility denial. Somewhere along our data flow, something fell out. And so we spent a lot of time and effort of really building a schematic so that we understood the data that was moving in our system, how it was moving, how it was transforming. And that took several months, honestly, Wesley, to be able to put that together. But it was one of the most valuable things we did because when we had that and we could see denials occurring, we could quickly go back and figure out where did we likely have something falling apart that we needed to pick up and bring on down through our data stream so that we wouldn't have these denials because denials were really, it was fighting what had been denied and preventing what could possibly be denied in the future if we continued our specific workflows that we had.
Right.
So that was a key area for us as well.
Right. Right. And this is as you talk about, this process, and I'm kind of thinking about maybe what people are listening about is, as you mentioned, could you talk a little bit about cross-functional teams and kind of about what you mean by that? And that I think maybe might be a good idea because what you're kind of explaining, I think, is commonplace, not just healthcare, but anywhere. But maybe if I'm thinking about this right, um, kind of a siloed setup, and maybe the cross-functional component of it really help break some of those down.
It it did. So when I talk about cross-functional teams, um, let me first go back and say the context that I think about them in. So the revenue cycle is the end of the
Hmm.
process of a clinical event. Um, the patient comes in, they have their medical event, and then it becomes a claim that we bill and collect for. When you start at the end, the only way you can change what's happening at the end is to swim upstream to what is happening before you. So when we looked at our cross-functional teams, we looked at them as cross-functional teams not only within the revenue cycle, so your different disciplines you had, coding, billing, collection, denial management, cross-functional there, but we also viewed it from a clinical perspective as well. And we were very blessed to have some of the doctors were very passionate about this particular space, and they wanted to lean in and help us. So as we were dealing with a particular denial class that we might have, we would engage the physicians from that particular space. I might have our chief of surgery sit in and we talk about why denials are happening. And then she was able to bring to the forefront, we aren't documenting XYZ. You need that data element to drop the claim, don't you? Yes, I do. Let me change my procedures here and make certain that we document X, Y, and Z. Or X, Y, and Z may be documented in a different space of the medical record, and that we just had to have the IT team go point to that place to pull the data element over for us without doing a clinical workflow. When we were looking at things around our lab, trying to ensure that we had some of the information passing over. There were some lab results that we did need to send in on a few things. I was working with our director of our lab to understand how they went through their workflows, how they documented their different activities, and then us being able to pick up that data where that data rested naturally in their workflows. And so I was very blessed with the facility that we worked for. Our clinicians cared about reimbursement. A lot of hospitals, the clinicians really don't want to get into the money side because that's the dirty side of healthcare. They want to be in the saving life side. They don't want to be in the writing the
Yeah.
paychecks every day side, which I
Yeah.
live in. But we were really fortunate to have some strong physician leaders that were passionate about ensuring that our facility received everything that it was due because they knew there were various challenges the community faced. They knew there were things that we needed service wise that we just couldn't afford to do at the time. And the way you fund those new service lines or close those gaps in care in our community is through making certain you get everything you're entitled to from what currently exists. Tribal healthcare is faced with a shortage of clinicians.
Mhm.
We had particular specialties that we desperately needed, but just couldn't find a physician or couldn't afford a physician around it. We had, a gap in cardiology. We desperately needed a cardiologist. Cardiologists are fat money. They're
Yeah.
very expensive. For me to be able to afford a cardiologist, I need to get everything working the way it should be working, so I've got the money to be able to pay for them. So when I think about rev cycle and it's, I said early on, it's not about the fiscal health of the organization. It's about meeting the needs of the community. And the way you meet the needs of the community is making certain that you are paid for everything you should be paid for so you can put those funds back into closing gaps in care for the community.
Right, right. No, that's definitely a good point. I think, as you mentioned, you're coming from a non-tribal setting and then coming to a tribal setting there, and then I'm not saying there's always an easier buy-in to something like reevaluating a process and whatnot. In a non-tribal setting, there's always going to be just different issues making that happen, but when going through a process like this and thinking about that, um, what are some of the other considerations to think about? I know maybe one thing you think of cultural considerations or, like you mentioned documentation, as you go through and your as people kind of auditing your workflow, like what are some things that you kind of learned, so
Yeah, I love that question. It's a very insightful question. So there are a few things that you have to think about when you're talking about a tribal setting. So trust and communication is vital in any tribal setting. Important in any, but particularly in a tribal setting, because your revenue cycle needs to present itself as being culturally sensitive and community informed. So I needed people that really understood the front end, the patient registration process. And when I say patient registration, it's where they come in and we do the eligibility verification and register them and do all the finance part of things so that we can get paid for those. Those are the front end activities that the patient first is experiencing. If they have a bad experience in that space, it sets the tone for their entire visit. We could provide the best clinical care to be had, but if coming in and doing business with us was terribly painful, it wasn't going to have the kind of flavor that you would hope. So really thinking about that and ensuring that we were approaching things in a culturally sensitive fashion. And when I say that, it's not just lip service. It's things like having translators readily available for our elders who may only speak Navajo, having individuals that were really trained to be able to explain what a CBI was and why it was important to get the CBI, having people that understood the geography that we were living in. In tribal settings, oftentimes you don't have a mailing address, so you don't have a street number. So you do have to think about those things, and when you're dealing with some of these somewhat haphazard, in my view, lines that have been drawn by IHS to where the service areas are, you got to know it's like, okay, if you're on this side of the mile marker, you're seen by one service entity. If you're on the other side of the mile marker, you're seen by the other service entity, and you
right,
have some coordination that has to be done there. So having people that understood those, which wouldn't necessarily coming from off reservation, they wouldn't necessarily understand those, but having a front end that was, we were very blessed with a lot of local people from our tribe that was participating in that. They could help navigate those various items. So that was an important area for us. And when you think about registration, it's, in my opinion, one of the most important aspects of your revenue cycle. Because if it starts off wrong, it's going to end wrong. Just
right,
simply put, the
right,
data follows you through the system. So if you don't get it right on the front end, it's not going to be right on the back end. So when we're talking about tribal settings, I think registration is one of the areas that's even more important than in a non-tribal setting. Because when we are talking about registration, that's where your most complexity exists, in my opinion, for tribal members. You do have the government to government relationship between the tribes and the United States government. So there are things that you have to do that are not present in non-tribal facilities. For instance, collecting the certificate of Indian blood. That was something we had to have. That was a key piece of information that we needed because it determined which payer was paying for that particular claim, which later turned into the amount of reimbursement because not every payer pays the exact same amount. So that is one of the areas that's far more complex than for a non-tribal facility. So that's why we put a lot of effort into that particular space and why it was so important to have a culturally sensitive and appropriate front end for us.
right, right, right. No, that's a good point. Kind of brings back memories to when I always remember I had to go with my grandparents and kind of interpret some of these things at the hospital for them. And yeah, I wasn't the best, but I kind of try to do it whenever my mom or my aunts were working and whatnot, and then my grandpa would have an appointment, and then he only really spoke Navajo, so it'd always be me going with him and trying to interpret what they were asking for, and so yeah,
It is.
yeah,
We
no,
we were
exactly,
blessed. Our hospital's leadership really understood that dynamic, especially for the elders. It was a little bit more common with elders than younger people, but they understood that dynamic, and we had a pretty robust language program for Navajo at our hospital. A lot of you can go buy that from a lot of translation services. It doesn't quite work for Navajo. It's just not the same. So we did use people that grew up in the community and grew up speaking the language and hearing the language,
Hmm.
trained in the medical terminology to be able to supplement our clinical staff and our registration staff, to be honest, as well, as we were trying to explain these concepts that don't quite translate from English into Navajo, uh, unless you're unless you're a native speaker.
Yep. Yep. No, it's definitely a good point. Good point. Well, Melissa, as we come to a close here, really just want to say thank you so much for sharing the insight on just how you came from an outside of Indian country, came in, saw some immediate areas where, you had some room of improvement, taking, best practices and, applying that. But I think, one of the biggest things that, I get from this discussion is the just the real kind of understanding that it's a layer by layer process, and that just took it step by step, really, right? And I think sometimes maybe, people who are trying to, go through this process maybe get a little overwhelmed because there's so much,
Mhm.
but really identifying that, so um once again, Melissa, I really just want to say, obviously you're pretty sure you've heard this. Yeah,
Yes, I have. Yes.
all
I
right.
my Navajo is actually terrible, so I won't even try. Uh, but yes, it can become overwhelming to try to tackle all these challenges. Um, so when we moved very slow and methodically, it kept us from overwhelming the organization, and we still produced tremendous outcomes for it. We brought in an outside firm that was truly revenue cycle experts, and we made a modest investment in that contract. We saw a tenfold increase on the
Wow.
money we put into that
Wow.
contract. It was huge. It was one of the best returns of any project that I've ever seen in my life. We saw things like, some classes of our denials drop by a quarter to a third, and when you're thinking about tens of thousands of visits a year, that's a lot, especially at the
Hmm.
AIR. We saw, just by being very methodical in our data flows, our information passing from our claim scrubber to the payers, that dropped by 90%, those errors did. And that just took putting some technology effort on it, because I couldn't throw enough bodies to manually fix these problems. But I put a little bit of effort in the technology space, and I was able to just take 10, 20% in one fell swoop and bring those through.
Yeah. Yeah.
So, yeah, that would be a strong recommendation of mine is to go a little bit at a time, and recognize that starting out, you're going to be a little slow in those returns because you got to fix the foundation first. But then once you fix the foundation, you can very quickly start seeing the returns come in. I'd say it was probably about a 6-month window from when
Okay.
we started our fixes to the point we started seeing the cash levels go up because it takes a while to do the fix and then do all the resubmission of the claim. So I would recommend that. The last thing that I would really say to your listeners is look at your revenue cycle as a strategic lever to positively impact the community. Yeah, it's a back office operation. It absolutely is. But this is the operation that brings in the revenue to be able to support the communities. So it's one of the most direct ways in my mind that you can strengthen your care for your people is to invest in this particular space and really embrace industry best practices because they're out there for a reason. And a lot of people have experimented and found out these work. They truly
Right.
work.
Right. 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 Well, Melissa, once again, thank you for your insight and really sharing your experience, and really hope this out and to some of our listeners, and they can use it to better their systems and operations. So thank you so much.
Thank you for having me today.